Thank you so much for having me here today. I want to start off by thanking Mark because I wouldn't be here in sort of this journey. He was the one who supported me when we first started doing pediatric obesity management at Children's and encouraged me to do the Obesity Learning Collaborative, which was his idea back 15 years ago. So I actually attribute a lot of what I have done so far to Mark. So thank you very much, Mark. Okay, so I am going to talk about something that I love to talk about, and I want to tell you why. It's medication in obesity. And the reason is because I've been doing this for about 2 decades, and our ability to treat this disease has changed remarkably over the past few years and really is exciting. And so I feel like we can offer patients some treatment now. I have no financial conflicts. And I apologize, I'm going to speak pretty fast because I have a lot that I want to cover. We're going to review the available medications, go over the clinical reasoning and monitoring and implementation, and then end with a case scenario. The first thing I want to state is the foundation of medication use in obesity management. And this is a quote from the 2023 American Academy of Pediatrics Clinical Practice Guidelines for Obesity. No current evidence supports weight loss medication use as monotherapy. So this is really important. We need to, as pediatric healthcare providers, also provide intensive behavioral interventions for patients and families as an adjunct to medication therapy. So very important that if we're going to start medication, we are also providing continuing lifestyle counseling. And that I feel like can't be understated. That's a big part of what we do. So when is it time to use medication to treat obesity? Lifestyle interventions have been ineffective in the following scenarios. Patients with a BMI diagnostic of class 2 or class 3 obesity, class 1 obesity with a comorbidity, and it could be a comorbidity like liver disease, it could be significant hyperphagia or binge eating. And then I just want to review the AP guidelines state that we should provide or offer medications for children 12 years of age and older with obesity, and consider or may provide medication for children 8 to 11 years of age and older with obesity. So there are a few off-label medications that you may see children on, especially kids who come to the Ideal Clinic. I'm only going to talk about one of them. We do use metformin, topiramate, and lisdexamfetamine. I'm going to talk about lisdexamfetamine. So this medication, of course, Vyvanse, blocks reuptake of norepinephrine and dopamine into the presynaptic neurons and increases the release of these monoamines into the extraneuronal space. We can start this at age 6 and greater for ADHD, but it is also FDA approved for 18 and older for binge eating. And off-label, we use it frequently for children who have loss of control with food, who have sneaking, impulsivity, and often clinically what I have found is that it's very useful in kids who may have undiagnosed ADHD. Sometimes starting a child on this medication can decrease a lot of the conflict that may happen in the house where you have a parent who feels like they have to police the child and the child is sneaking food. The starting dose, we can start as low as 10 milligrams depending on the age of the child and titrate up to effect. We monitor every 1 to 2 months and follow blood pressure. And of course, you want to be cautious in kids with hypertension, congenital heart disease, arrhythmia, or anxiety. There's unfortunately not any really good data on BMI reduction with Vyvanse. I can tell you or lisdexamfetamine, I can tell you clinically that I find that it can be very useful with kids who end up having actually undiagnosed ADHD. It seems to work well in some of those children. So now I'm going to go to the FDA-approved medications. So we have phentermine, and topiramate, and the GLP-1 receptor agonists. We have semaglutide, liraglutide, and tirzepatide. Tirzepatide is actually only FDA approved for 18 and up at this point, but I do want to talk about that for a few moments. So first of all, phentermine, which is a medication that has been around since the 1950s. It's a sympathomimetic anorectic, which is a norepinephrine, serotonin, and dopamine reuptake inhibitor. It's FDA approved for 16 years of age and up, and only for short-term use for 12 weeks. So off-label, we use it with topiramate, we use it for younger kids to manage hyperphagia and obesity, and using it for longer than 12 weeks is considered off-label use. Dosing can range from 4 milligrams to 37.5 milligrams, and you want to monitor blood pressure and heart rate. Adverse effects include anxiety, hypertension, palpitations, dry mouth. It is contraindicated if you have someone who has uncontrolled hypertension, congenital heart disease, severe anxiety, arrhythmias, or a history of substance abuse or substance use. And you want to be very cautious when using this with SSRIs because of the possible risk of serotonin syndrome, and also be cautious using it with someone who's already on a stimulant. I tend to not use this if I have someone who's already on, for example, an ADHD medication. There's limited pediatric data on BMI reduction. One study in adolescents did demonstrate 3.2 kilo and 4.1% BMI reduction at 6 months. The problem with using phentermine alone is, unfortunately, after a few months, you develop tolerance. And that can be really frustrating because kids will start, and the first 1 or 2 months, they'll have great success, and then it just doesn't work as well. But phentermine and topiramate is another story. Now, this is a medication that these two drugs have great synergy. It is FDA approved for kids 12 years of age and older with obesity. And I have this table here that shows how we start phentermine and topiramate. So the brand name is Kisimia. And so in the second column here, you see that you start with a very low dose, 3.75 milligrams of phentermine and 23 milligrams of topiramate. So that comes in one pill, and kids would take that for 2 weeks. And if they tolerate that, then you move up to the middle dose, which is 7.5 and 46 milligrams. You stay on that for 12 weeks. If they don't have at least a 3% reduction in BMI, you go to the next level. And so then you do another 2 weeks at this higher dose, and then you end up with the highest dose being 15 milligrams of phentermine and 92 milligrams of topiramate. Now, the third and fourth column have just phentermine and topiramate because, as it frequently happens, and I'm sure you've experienced this, a lot of the insurance companies are not covering Kisimia. And so, but you can get the same effect by prescribing phentermine and topiramate individually. And usually I will start with young kids. If I have someone who's really young, the 4 to 8 milligrams is reasonable for phentermine, and then starting with the 25 to 50 milligrams of topiramate. But kids who are about 12 years of age and older, I tend to have them get the 37.5 milligram, which is the highest dose of phentermine, and cut it in half, just because it's more cost effective. Because again, even the insurance company may not even cover phentermine. And so you can get a good RX coupon, and you can get that medication for about $15 to $20 a month. So I usually do 18.75 milligrams and then 25 to 50 or 75 milligrams of topiramate, and monitor very closely and adjust as needed. So we want to be monitoring blood pressure, heart rate, do a pregnancy test at initiation if needed, creatinine and bicarb. Adverse effects include paresthesias, dizziness, insomnia, constipation, arthralgias, depression, and topiramate is considered a potential teratogen. So we have to continue to monitor pregnancy risk. It is contraindicated in pregnancy, in glaucoma, hyperthyroidism, and any history of substance use. And of course, you want to be cautious when you have someone who has an arrhythmia, a history of arrhythmia, hypertension, or SSRIs. So just to recap, if you don't have Kisimia coverage, you can do the two separately, and I often do a half of a 37.5 and a half of a 25 or a 50 milligram of topiramate. You still will get tolerance after a year. But sometimes you can get a lot of, you can get good efficacy with that combination of medication. And then you want to do a pregnancy test at initiation and periodically. So why do we consider using this medication? Well, it was FDA approved. Kissimmee was FDA approved in 2022 or 2023 after a study which showed that in that middle dose, there was a 10.4% decrease in BMI compared to placebo. I'm sorry, 10.4%. This was in the top dose, decrease in BMI compared to placebo. And in the middle dose, there's an 8.1% decrease in BMI compared to placebo. Which is remarkable. But what I think is the most exciting is the fact that when they looked at cardiometabolic parameters, there was improved triglyceride and HDL in treated patients. And that's really what we're after, right? We want to improve kids' cardiometabolic health. And this medication showed that after 56 weeks, these kids actually did have improvement in their cardiometabolic measures. So let's talk about the GLP-1 agonists. We have the mechanism. There's multiple mechanisms. I'm going to talk about the two main ones. They decrease hunger by slowing gastric emptying and targeting the satiety centers in the hypothalamus and neural pathways, which are associated with pleasure with food, increases insulin secretion and glucagon, and decreases glucagon secretion. So it really provides a lot of good insulin sensitization. Two of these medications are FDA approved for kids 12 years of age and older with obesity. Adverse effects, most of them are going to be gastrointestinal, nausea, constipation, vomiting, abdominal pain. Some kids will complain of headache, dizziness, fatigue, hypoglycemia, cholelithiasis, and cholecystitis. To minimize these GI side effects, really need to make a lot of changes in what the patients are eating. So you want to aim for, you want to aim for the lowest effective dose and make sure they're choosing smaller portions. And it's easier to do that when you're on this medication. Avoid greasy, spicy foods and rich foods, and drink a lot of water. You can use ondansetron when you're doing dose escalation or you're first starting. But I would say that if you are needing to take ondansetron to take your GLP-1 agonist, that medication is not the right medication for you. But I will tell you, there are children who don't want to come off because nothing has worked in the past. So it is definitely a challenging discussion to have. It is contraindicated. These medications are contraindicated if there's a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. And you want to be cautious if there's a history of pancreatitis, renal impairment, or insulin use. So this is Saxenda. Saxenda is the brand name of liraglutide. And the only reason why I put this up here, I just want to show you it's a multi-dose pen. It's pretty easy to use. Saxenda is FDA approved for obesity. Victoza is FDA approved for diabetes. So they're the same medication, but the brand name tells you which one they're approved for. My experience recently has been over the past year is that you cannot get the medications that are FDA approved for diabetes for patients anymore. In the past, they didn't really care, but now they really want to see if there's a diabetes diagnosis. So Saxenda is approved for weight management, and it is a multi-dose pen. And the way you start it is you start at 0.6 milligrams. It's given daily, and you escalate after 4 weeks to a max of 3 milligrams. And that's considered the maintenance dose. I would say, though, that if you have someone who is doing very well on a lower dose, stay at that lower dose. And by doing very well, tolerating the medication, not having a lot of GI side effects, and losing about 1 to 2 pounds a week. So you don't want to be losing more than that. You want to make sure they're not overly restricting, they're continuing to eat healthy meals. And in that scenario, you can stop at whatever level that it works best for them. And so liraglutide was FDA approved after a 2020 study demonstrated in adolescents. There was a 4.6% decrease in BMI compared to placebo and a 4.5 absolute decrease in body weight. But there was no statistical significance in cardiometabolic variables in the quality of life measures between kids on placebo and kids on the treatment arm. Okay, want to make sure I get through the rest of this and get to our case study. So I just want to tell you there was also a recent study in 2025 where they looked at the same medication in kids down to 6 years of age. And just the data was a little more impressive, but still no difference in cardiometabolic variables. This is Wegovy. So the next one that I want to talk about, Wegovy is the brand name for semaglutide. This is what is FDA approved for weight management. Ozempic is only for diabetes. So Wegovy comes as single use pens, and it is given once a week. And you start at 0.25 milligrams and you can go up to 1.7 or 2.4. Those are both considered maintenance doses. But I can tell you this medication, I have had some kids who do great on just 0.5. So you really go to the lowest effective dose. And this was approved after a 2023 study, which showed that there was a 16.7% decrease in BMI and a 15.3 kilo absolute decrease in body weight. But the two things that I really want to stress, which I think are so exciting, is they did a post hoc analysis and they looked at all the data. And what they found was that of all the kids who started and were on the drug medication, the semaglutide, 44.9% of them by the end had a normal BMI or a BMI in the overweight range. So these are kids who started with class 1 to 3 obesity. And that to me is remarkable because having been working in this field for a long time, we had nothing that we could offer children that would give them this success. But what's even more exciting is that all these kids had improvement in lipids, waist circumference, ALT, blood pressure, hemoglobin A1C, and quality of life. So we have kids who on the medication really had good success. And then lastly, Zepbound is a single-use pen. It is approved for 18 years of age and older. And I just want to show you the data on that. This was in adults, 72-week randomized trial, 15% weight decrease with 5 milligram dose, up to 20.9% weight decrease with the 15 milligram dose. Ongoing trials right now in adolescents, hopefully we will have good data. It's probably not going to be till 2027, but I am really looking forward to seeing that data and seeing if it would be FDA approved down to 12 years of age. Additionally, adults in this study had improvement in waist circumference, blood pressure, insulin, and lipids and prediabetes. So a lot of good cardiometabolic outcome. So I want to just conclude by going over a case study. And this is a patient that I had in Ideal Clinic. And probably will resonate with many of you, patients that you've seen, 17-year-old who presents for weight management. She reports that she has been heavy since childhood, but gained weight rapidly over the course of the pandemic. She attributes her weight gain to portions and to a deterioration in the quality of foods that she's eating. She's tried to improve her eating habits, has lost 10 pounds, but can't sustain this weight loss. And this has been very frustrating for her. She reports frequent loss of control of food almost daily, and she skips breakfast most days of the week. On physical exam, she has a BMI of 44, which is diagnostic of class 3 obesity. She has dark hyperpigmentation around her neck. She has some crowding in her pharynx and Mallampati score of 2, ALT of 70, which suggests that she probably has liver disease, hemoglobin A1C of 5.9, which is diagnostic of prediabetes, and she has an elevated triglyceride on her lipid panel and an elevated insulin. So in summary, we have a young lady with class 3 obesity with acanthosis nigricans, prediabetes, metabolic dysfunction-associated steatotic liver disease, which is the new name for fatty liver, frequent loss of control with food, and possible obstructive sleep apnea. And so the first thing we want to do is family-wide lifestyle modification. So talking about ways we can improve the structure of her meals, the quality of her meals. And then we had a discussion about medication. So we talked about metformin. So someone with prediabetes would be something to consider. BMI reduction with metformin tends to be pretty minimal, maybe about 1 point. Vyvanse is another thing. She has loss of control of food. However, she has a disordered eating pattern in that she's skipping breakfast. I don't want to put someone on Vyvanse who's already skipping a meal because I'd be worried then she'd skip the next meal and then eat more at the end of the day when she has rebound hyperphagia. So Vyvanse didn't seem like a good choice. Semaglutide or liraglutide, that's what she really wanted to be started on, but was not covered by her insurance. So we decided to give phentermine and topiramate a try. And then we also discussed bariatric surgery. And so this is her growth chart. She lost 53 pounds over 5 months, which is a little bit higher. So it's about 2.5 pounds per week. So we definitely were following her very closely, had my RD meet with her. We talked about how she was eating. Her mother was coming with her to visits. And this is a young lady who was eating structured meals, was not skipping meals anymore. I felt very confident that she was getting the nutrition she needed. She had an 8.5 point reduction in her BMI. So her BMI was now 35.3. So what's her clinical response to treatment besides those numbers? Her hemoglobin A1C at 6 months was normal. Her lipid panel was normal. She did not snore anymore. She had a normal insulin level. She had a normal ALT, and she had a decrease in her obesity classification. She went from class 3 to class 2. So what were the strengths? Why did this patient respond in this way? I mean, she had a lot of family support. I think that that was a big part of why she was able to achieve this success. She had someone who was her coach at home, was helping her through this process. She had structured meals. She was particularly sensitive to this combination of medication. One thing I want to stress is that obesity is so heterogeneous. So you will have I have some kids who don't respond at all to these medications. I've had kids who gain weight on GLP-1 agonists. So everyone responds differently. And she was extraordinarily sensitive, and she was very motivated. She was a young lady who also played soccer, and with the weight loss, she felt like she could do more, and she was very happy. So in this situation, success begets success. So it really made a difference for her. And so what are the next steps? And there's always a question, how long do I have to be on this medication? That is a hard question to answer. The answer is indefinitely. You need to be on the medication if you're tolerating it, if it's working. At some point, your BMI is going to be stable. And if it's at a good place and you have good cardiometabolic parameters, you stay there, and you may stay on the medication, stay on it. You can come off for short periods of time. It's really something that we don't have an algorithm for right now, but we need to, each person is different. And we want to definitely increase physical activity. That's the key to keep maintaining BMI. Prepare for relapse. Unfortunately, that does happen. The medications stop working. 1 to 2 years after starting, I've definitely seen even GLP-1s that worked beautifully. After a couple of years, the brain figures out how to get around it. And then talk about next steps. And just to end this little story, I will tell you that she did really well, was very proud of herself, stopped coming to see us, stopped the medication because she did not want to take medication anymore. And then came back a year later. She had gained all the weight back. And at this point, she decided she really wanted to have a sleeve gastrectomy. And so she did end up going and having a sleeve gastrectomy and did well from that. But that was her journey. And this is sort of kind of the things that we did along the way. So these are some resources that I just want to highlight. ObesityAction.org is a great website. Has a lot of information about surgery and medications. The Peds Endo link has actually is a good guideline for starting medication, tells you what to look for each of the medications. It's really a wonderful resource. And then the Ideal website for referral criteria to Ideal Clinic, and then the algorithm that's available on the Pediatric Health Network. And I think I just... Any questions? I think we can take one question or